Yeah. So also, if someone can volunteer and uh, admit the doctors, please. If someone can volunteer and admit the doctors, that will be very helpful because sometimes I can't see the screen while we are doing the case. Okay. So anyone, if you can't see any notes there and there is doctor in the waiting area, just admit him, please. Is Dr. Sophia ready?
Yes, I am.
Shall I open the 3 minutes timer
Yes,
for
you
you?
can.
Yeah, okay.
Is it just this page?
Oh, yeah. You want more?
No, I'm just thinking like no blood test, right? Okay.
Well, then you might then order some blood test. Yeah. So,
Okay.
yeah, if you think about it, then you might use it in your management.
Mm. Okay, we can start.
Yeah, I just want to make sure the recording is working or not. Okay. Otherwise, we will lose all the points. Let me just double check. I'll just double check the recording and then we can start. Yeah, recording is working. You don't want to discuss, yes? You want to go through it directly.
No, that's fine. Maybe we'll discuss in the end.
Yeah,
What's the
better
patient's name?
because if I discuss it, we will destroy it. Yeah, so better to see how what you will do. Okay.
Okay.
The doctors, are you seeing the can you confirm you can see this screen, yeah? The patient screen, yes?
Yes, yes.
Yeah, just because I don't know why I'm not seeing the other doctors here. Okay, so I will open your 12 minutes. Okay, and you can see the timing here. You can see it, yes?
Yes.
Okay, I will open
Where is the timer? Sorry.
here. Can you see? Yeah.
Yeah,
On the
I can
right
see
side.
on the other.
Yeah,
Yeah,
you
that's
can
fine.
see?
Yeah.
Yeah,
Yeah,
okay,
now.
good,
Yeah.
good, good. Okay, good. So let's put this up a little bit and then I'll put the timer. Yeah, we can start.
Hi, I'm Dr. Amjad. Is that Jack English?
Yeah, doctor.
Right. How can I help today, Jack?
Oh, doctor, to be honest, I'm not sure, doctor. I wake up in the morning and my face is little bit, my left side of the face is a little bit funny.
Mm.
Um,
Yeah, I can. Yeah, I'm sorry to hear about that. I can see in the pictures. Do you want to tell me more about it? What happened exactly in the morning?
well, to be honest, I'm not sure, doctor. Yesterday, but I feel my face was a little bit numb, okay, and my eye was watery, and then I said, okay, maybe common cold or something, or I'm tired. I'm not sure. And then um, I went to sleep, and then when I wake up in the morning, I just find my face, look funny. I don't know. My left side of the face is not moving.
Mm.
You
Okay.
know, I was worried also. Because my neighbors said to me, "Well, you might have a stroke." And I said, "Okay, I should then call my doctor."
Right. Okay. So you were worried about stroke. Was there anything else you were worried about, Jack?
Well, the stroke is not enough, doctor. It's true. I am,
No.
yeah, but yeah. So this might be then a stroke or what?
Yeah, I mean, I'm going to ask you a few more questions, Jack,
Okay.
but before I tell you, explain you in a better way. So, is this the whole left-sided which is affected?
Well, I think so, doctor. I'm not sure because also the nurse asked me that, but I'm not understanding what it means the whole left side because I'm not getting. So she did. She sent me some instruction to do some movement, and I take photo of it and send it to you. So
Okay, that's fine, Jack. I've got photos with me. Few more questions, Jacks. Um, apart from stroke, are you concerned about anything else?
no, to be honest, I hope it's not stroke.
Yeah, okay, right. And when it happened, did you have any headache in the morning?
No, I didn't notice, to be honest, any headache, doctor.
Right, okay. Sometimes like people who have facial weakness can also have like limb weakness. So have you had any arm weakness or leg weakness at all?
No, no.
Right. And did you notice any speech difficulties?
No, my speech I think is fine, but whenever I'm trying to eat or drink, the water is coming out of my mouth.
Right, okay. Is there any swallowing difficulty, Jack?
No, I didn't notice, to be honest. No, I think I'm swallowing fine.
Right, okay, Jack. And sometimes it can be related to certain infections as well. So have you noticed any fever?
No,
Right, okay. And any neck stiffness?
no.
And any rash over the body at all?
Uh, I mean, where exactly, doctor?
I mean, like anywhere in the body. Have you got any rash?
Well, yeah, I have a rash, doctor, but I thought it's not related.
Hmm.
I think yeah, I will send you a photo of it, so I'm not sure. Did you see it?
Yeah, thank you for sharing that. Yes, I can see the rash. And how long it's been like this for, Jack?
Well, the rash I think appeared from 2 days, but I thought it's not related. It's in my ear.
Okay. Is it painful at all, Jack?
Not much, but a little bit annoying. So I took some cocodamol and it helped a little bit with it.
Hmm. Right. Is it itchy at all?
No, it's not itchy.
Right. Okay. And have you got any ear pain along with it?
A little bit of discomfort, I would say.
Yeah. Okay. And by any chance, is this affecting your hearing at all?
No, I didn't notice any problem with my hearing.
Right. Okay. And Jack, has it ever happened in the past?
No, I think this is my first time, doctor.
Right. Okay, Jack. I can see you are on medication for blood sugar and high blood pressure. Are you taking them?
Oh yeah, doctor, yeah.
Hmm. Okay. Right. Okay. And obviously, Jack, I'm going to suggest whatever is best for you today. Was there anything in specific you were hoping?
Well, I was hoping that you will tell me I don't have a stroke. That's all. And if it's
Yeah.
not stroke, what we should do, because I don't know how I will drive with this eye. A little bit annoyed. I can, a lot of secretion coming out, a lot of tears coming out. It's affecting my vision. I cannot drive.
I hear you're quite worried about it, isn't it? And you mentioned
Mm.
driving. So I mean, what do you do for a living? Do you drive or
Well, I'm a lorry driver, doctor.
lorry driver? Right. Okay. It must be really difficult. So how are you coping then? Are you going to work with this or
Oh yeah, yeah. I'm going to work, but I find it a little bit annoying. To every now and then I need to remove the tears. I'm not sure why my tears, my eye is excessively tearing. I'm not sure why. There's a lot of tears coming out.
And are you able to close your left eye at all?
Well, uh, to be honest, not completely, doctor. So yesterday I struggled to sleep. I'm not sure why I feel light coming on, but I'm not sure if my eye is closed or not when I'm sleeping.
Mm. It sounds like you're going through a lot, and these symptoms have been affecting you. Um, who else is at home to look after you, Jack?
Well, my wife is there.
Right. Okay. Okay. And by any chance, do you smoke?
No, doctor, I'm not a smoker.
Well done. That's a good thing. And what about drinking alcohol?
Well, no, I'm not drinking. I don't drink.
Right. Okay. Fine. Okay. Okay, Jack. I think from what you have told me and looking at the pictures as well, I think it's really important that we bring you in for examination.
Okay,
Yeah. So looking. I mean, I just want to reassure you. It doesn't look like stroke to me.
okay, that's good. Okay,
So it does look like what we called as a facial nerve palsy. So the specific name for this is like Ramsay Hunt syndrome. Have you ever heard of it?
oh, no. Well, who's Ramsey, doctor? No.
Right. So obviously, I think it's the name after the scientist who kind of discovered it. But what
Okay.
happens is like it starts with like a rash in the ears, the similar symptoms which you had, and then it kind of affects your facial nerve. So
Mhm,
facial nerve is a nerve that supplies your face,
mhm.
and it also supplies the muscles which helps with eye closure. So it seems like your one half of the face is affected, and it looks like the left side is affected, and that's why you're struggling to open the eye. And also, I can see your um, mouth is deviated towards one side.
Okay, but from where I get this infection, doctor?
So these are, I mean, like this can happen after a virus, um, which can cause these vesicles in the ear and then leads up to facial nerve palsy.
Yeah, but from where I get this virus?
So you can get it from anywhere, Jack. I mean, like sometimes it can be transferred by contact with other person who have got a similar virus.
Hmm. Okay, but I can't remember that I came in contact with anyone, to be honest, that have
Yeah.
something like that.
Yeah.
However,
Okay.
that's fine. So you want me to come today, doctor?
Yes, I think it's really important that you come in today.
What you
I know you
want?
meant. Yeah.
Yeah, so what you want to examine, doctor?
Yeah. So I think we obviously I'll examine your pulse, blood pressure, temperature. We'll have a look in your ears as well, and we'll examine other nerves of the body. Um. Yeah.
Okay, sure, sure.
So, I mean, in order to treat this, because you mentioned like it just started in the morning,
Mhm.
um, so we are still within the time limit of starting some steroid tablets. What are your
Okay.
thoughts about that?
Steroid, steroid is not decreasing the immunity, doctor.
Yeah, so
Because you
I
said
mean,
it's
like,
infection, so how you will give me steroid?
yeah, okay. So what happens, Jack? I do understand your concern that you're worried like steroid can lower the immunity, but if they're given for a short time period for specific condition, the benefit outweighs the risk.
Mm-hmm, mm-hmm. Okay, doctor,
So
but yeah, okay. So what exactly that steroid will do?
So, I mean, in the steroid, what we give to you is like prednisolone.
Mhm.
It is usually given for 10 days. And it kind of reduces the inflammation that
Okay,
in turn helps with, um, treatment.
okay, that's fine. But what about my sugar? Did that affect my sugar level, doctor?
Yes. So sometimes it's very important to monitor your blood sugar level while you're on steroids because it can temporarily go up if you have got diabetes.
Oh, okay,
And you
okay.
mentioned you're worried about driving. I think, Jack, it's really important that you get better first before you drive. Any chance you can take some time off work?
Well, I think so. Yeah, if you will give me fit note or something, doctor, that will be helpful. Would you be able
Yeah,
to?
yeah. So I mean, we can definitely help you with the fit note, but usually for the first 7 days, we ask you to self-certify. So self-certifying means you can just inform the manager at work that I can't come in for 7 days, and then if you need further fit notes, we are more than happy to help you.
Okay. Well, so do you think it will cure in 7 days?
I mean, like it's really, I can't say like it's going to get better in 7 days because in some people it can take few months before it settles.
Oh, a few months. Okay,
Yeah.
okay, okay. It
Um.
seems serious. Well,
Yeah. I mean, like it's not a life-threatening condition, but it can sometimes take longer to recover.
okay, okay. That's fine, doctor. So
And
I
you
mean,
did
you will be
mention,
able to treat it in. Do I need to see the specialist?
yeah. So I mean, at the moment you mentioned like you've got some blurring of the eyes because you're having watery eyes and you're unable to close them.
Mhm.
Um. At the moment, I think it's fine. I think we can just keep an eye on you. We'll bring you for follow up and see how you're doing. Um, you don't need any specialist referral at the moment.
Okay, doctor. I will come today. So you want me today to come?
Yeah, is there anyone who can bring you in?
Yeah, my wife can drive me.
Okay, that's fine. I think time is up, isn't
Yeah,
it?
yeah, yeah. It's up. But you tell me, did you want to say something else? Because you are half-half in the management, half-half.
Yeah,
Yes.
maybe blood test or I don't know.
Okay, what else?
Eye patch, isn't it? Or
Yeah,
something
okay,
to
what
help with.
else? You need
Um,
you need you need a lot of things to take that 3.5 mark or 4 marks in the management, if it's not more.
Safety netting, maybe.
Okay, no, what else? Well, you diagnosed the case, but I think because you just read maybe partially about Ramsey-Hunt syndrome, do you give him antiviral or not?
Yeah, I don't know. I don't know. I can't remember.
No, you give. This is not Pill's palsy, okay? This is not a Pill's palsy case, okay? This
Okay,
is Ramsey-Hunt syndrome that you need for sure. If you didn't give,
acyclovir.
if you didn't give a cyclovir, this is a failing point, so take care. Okay, what else?
Can I just ask one thing? Um,
Yeah.
when he was saying in the beginning about the stroke and he's worried and concerned, so does the empathy element comes there? Like, do
Well,
we have
empathy for his worries. I mean, you can reassure him and calm him down, and then when you see the definite diagnosis, then
yeah.
you will tell him that's not stroke. I think that will be more than enough.
The reason I ask because when I make video and I discuss with my supervisor and she says that the empathizing sentence should be different. Like she was feeling that mine is dramatic, it's not real. So I was like, okay, it should be real. That's why.
Traumatic. What? I'm not getting. Sorry. Uh-huh.
Like when we are saying that I'm really sorry what you're going through, so that looks
No,
like
no, that's
not
excessive.
real.
Yeah, for sure. Yeah, for sure. This is excessive empathizing. This is not real. That's not good.
Yeah.
That will
So
destroy the interpersonal skill. Yeah. You
and
cannot every sentence you will say, "I'm sorry to hear that." You can't do that you will not finish in the 12 minutes for sure.
yeah, and then so
But you might say, "Yeah, your concern is valid. We will do our best to help you and have better understanding about the situation."
and Sophia did very well.
Well, I think she did fine. Yeah.
Yeah. She did well.
Yeah, she did fine. Yeah.
Yeah.
Oh, just who is with me because I'm not recognizing the voice. Who's the doctor who's talking? Sorry, because I
It's
can't.
me. I'm Sarah.
Okay, Doctor Sarah. Sure. No problem at
It's
all.
my
No.
first time. Thank you so
Yeah,
much.
no
And you're
problem. No
really good.
problem. No problem. Thank you. So, Sophia.
Yes,
Yeah, 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 yeah. So you see, even the people are saying the other doctors saying that you are good, but unfortunately, I
No,
will
but they
fail
can
you.
fail you, isn't it?
No,
If you
I
don't
will
know
fail
cyclo.
you. No, yeah, I will fail you in the case. Yeah, you did good. Your interpersonal skill is good, but unfortunately, you would fail in this case if you didn't say this management, treatment plan. If it's not accurate, the possibility that you will pass is scanty. Okay, and there
Mm.
is a multiple issues that you need to emphasize in the management plan. We will discuss it. Okay, but you tell me your reflection about how you did and what you might do it in different way because that will increase the chances of your learning. And then I will tell you what I would like you to do in the management. And then we will go through the facial nerve, paralysis in details in the PowerPoint. And I hope also the other doctors, please, to engage like Dr. Sarah did. Okay. So tell me what you would do in different way if you did the case again.
Maybe I can be a little bit quicker. I think I was taking a lot of time.
Because you was thinking, and it's fine to think, especially the differential diagnosis of the facial nerve palsy is a lot, okay? But the way to come through that, I'm thinking it in three levels. Again, the rule of three levels, okay? First, is it upper or lower? Okay. Second, is Pill's palsy or not? And if it's Pill's palsy, is for me or not? Okay. And if it's not Pill's palsy, then what it is and how should I treat it? So if you think in this way, I think you will be faster. And your differential was okay. Okay, I think you was thinking about meningitis, and you was thinking about ear infection or middle ear infection, and you was thinking about stroke, isn't it? This what
Yeah,
I
maybe
got from the
maybe any
differential.
dental treatment or anything. But if when I asked about rash, the diagnosis was quite obvious. So I'm not sure how much differential then we should ask.
Well, for me, I always advise three differential will be more than enough. Okay, because
Okay.
you will not have more time to you can't exclude all the differentials in 12 minutes. You need to pick up the most important three differentials, okay? And in this way, upper or lower, pills or not, and if it's pills palsy for me or not, okay, it's the fastest way, okay, to exclude the other differential. Um, Asking about trash was crucial here because most of the people will not ask about trash, and then I will not disclose the other picture. Okay, I will not say that I have a rash except at the last 10 seconds, and then you will realize that the case gone from you. So asking about trash was a good point. Okay, so always with facial nerve paralysis, you need to ask about trash, you need to ask about trauma as well, but if you don't have time, that's okay. But trash is important. Okay, it's very important to ask about trash because it's a differential point. What is the cause and how you will treat? Is this a Pill's palsy where you will not use the cyclovirate, or it's Ramsey Hunt syndrome, was it, zoster oticus, okay, which is, I think you didn't know that. Well, this is a herpes zoster infection, okay? It's not a herpes simplex or idiopathic paralysis. This is a herpes zoster infection. So you need to emphasize that to the patient. And then when I ask you from what I get the infection, you didn't answer the right answer.
Yeah, so it's like the chickenpox virus that stays in your
Exactly.
body.
So yeah, so explain it to the patient. Let me see how you will explain it, please.
Okay, from where you got the infection, right?
Yeah, from where doctor I get the infection?
So I can see you're worried about like where have you got the infection from. What happens is like when you have chickenpox in childhood, sometimes the same virus can stay in the body and can present later in life, leading to vesicles in the ear and sometimes leading to facial nerve palsy as well. So we
Okay,
call this
okay.
virus the herpes zoster virus.
Okay, doctor. So why now it's becoming active?
So sometimes it can become active when your immunity is suppressed, and um yeah. So when you're feeling run down or having cold, you've got history of diabetes as well, so
No,
that can make
yeah,
you
related, yeah, exactly, related to the patient. So related that he have a diabetes, and then that you need to use it in your management plan, isn't it? So you
HbA1c
need,
one.
yeah, you need to ask, this patient doesn't have bloods, although you are in the beginning said, where is the bloods? So you tell him, you need to ask him, when was the last time you have your diabetic check? He will tell you, well, from 1 year ago. So you tell him, okay, it's worth, to check your diabetes level, okay, your hemoglobin A1C. And also when you come in, we'll check your blood pressure, and also we'll do some blood tests to check your kidneys and your urine. So ACR, and, it's important as well. So don't forget that, okay? If there is patient with herpes zoster and his diabetes, don't miss the diabetes level in it, okay? Because it will have a mark. Is it controlled or not controlled? What else? Sophia, what else you will
Yeah.
do different?
Like you said, maybe blood test,
Okay.
thinking in a different way, like a diabetes can lead
Okay, so now you know that
immunocompromise.
it's herpes zoster. Then what you will do for, yeah, you suddenly you will add acyclovir, you will add prednisolone. Well, first, what is the dose of the acyclovir?
Is it 800 milligram 5 times a day
Yeah,
for 5 days?
exactly. For how long?
5 days?
7 days. 7 days.
7 days.
1 week.
Okay.
Yeah, 1 week. And what is the side effect?
So, like every
Neuralgia.
medication.
Well, neuralgia is for the herpes zoster, but when you prescribe a medication, you need to see at one or two of the side effects of the medication. So what is usually you will say for cyclovir?
Do you say that sometimes it can affect kidney? So make sure you maintain adequate hydration. Or
Yeah, kidney is less likely, but it's more affecting the liver. Yeah, liver and photosensitivity and diarrhea. Okay, abdominal cramps. Okay, yeah, kidney less likely. Okay, yes, when the patient have a kidney injury, you need to reduce the dose of dicyclovir, do renal modification, but also it's very rare that it will directly affect the kidney because the cyclovir metabolism usually is done by the liver. Okay,
right. So liver
then
diarrhea and photosensitivity.
yeah, it can cause photosensitivity. Yes. How you will explain photosensitivity?
So sometimes it can cause your skin to be more sensitive to
To
sun
light.
exposure.
Yeah,
Yeah,
light
right.
or sun exposure, you can have rash. So if you had a rash other elsewhere, okay, it might be related to the medication, not spread of infection. And the other, what other medication is causing photosensitivity that you need to know about, doctors?
Doxycycline.
Doxycycline. Okay, that's good. Um, so now you know that it's herpes zoster. What is related to her? Which one of the doctors said that, yeah, there might other complication that the rash can go, and then you have post-herpetic neuralgia. You might say a little bit of about post-herpetic neuralgia pain, or what else you need to tell the patients regarding herpes
Isolation.
zoster. Well, isolation, yeah, for sure. Yeah, isolation if there is any pregnant lady around or any immunocompromised. What else? Which is important also for
If
diabetic
it
and
goes
having
near the
herpes
eyes,
zoster.
or is it like if
Well,
it
yeah,
goes near the eyes?
eye closure is important, but in the herpes zoster bit, because we didn't finish yet the complete management of herpes zoster.
And can it spread to the eye, the rash?
I think
Yeah, well, yeah, you can
you
have
two
herpes
hours
zoster.
and red flags.
Ophthalmicus.
Herpes zoster opticus, and we had one
Ophthalmicus,
case of
yeah.
her. Oh yeah, herpes zoster ophthalmicus. We had one case. I think the first video that I did, but also there is other thing, doctors. There's another thing that when the patient have herpes zoster, you need to emphasize. You need to sell it.
If they're having like signs of what do you call it, encephalitis.
Well, that's fine.
It
This
is
is in the
shingles
safety
vaccine.
netting. That is in the, yeah,
Safety
yes,
netting.
Someone says shingle vaccine. Who?
Shingles vaccine.
Yeah, vaccine. Please try to sell the vaccine. Yeah, you are for sure you are seeing the posters in your clinic about promoting, zoster vaccination. So this patient is, yes, 56, but he's diabetic, so he's considered as immunocompromised. So usually you might, give him the vaccine earlier, okay, earlier than 60. Okay. So what else you want to do in the management? You said safety netting, I think more than enough. Although, there is a lot you can say about the safety netting. Okay, confusion, pain after treatment, and what else? Dissemination of infection. What else you would like to add in the management?
Follow up.
Yeah, follow up. Exactly, follow up. Because the problem is with these cases, if you ignore them and then you need when you bring him in, you need to grade the weakness of the nerve, yeah? The weakness of the nerve, because if the patient is not improving, yeah, within 3 weeks, no improvement, or then no complete recovery after 3 months, it's as pulse palsy, okay, you need to refer him to ENT, okay, because he will need, assessments by the specialist. He will need a specific referral to the physiotherapy, where they can give them, galvanic treatments, yeah. So sometimes the recovery of the nerve will not be 100%. So referring them, okay, to avoid complication if there is no improvement in the 3 weeks. So following up them every 2 weeks or every month is important. Okay. Usually I'm following them either pulse palsy or any facial nerve paralysis that I'm holding it in the primary care. I'm seeing them every 10 days. Okay, until I feel satisfied that there is a recovery rate and it's good, then I will, might see them every month. Okay. Otherwise, if there is no good recovery, I will refer, because it can cause permanent damage. You don't want to cause permanent damage for a patient in his face. Is that clear?
Yes, thank you.
Yeah. Then let's coming then to the feedback. So yeah, opening statement was fine, but you didn't use pre-existing information. Take care. Okay. Your differential is okay-ish. Okay. I can see that you use the windows of opportunity well, and well done for doing that. Okay. And then the psychosocial and the ICE was also asked in non-formulaic way, except I think in the beginning, I think in the ideas, how you ask about ideas, because I think one of them was a little bit formulaic. Um, can you remind me how you ask
I
about
think
ideas?
I think I've
Sophia
asked
asked
consent
that, what
twice.
do you think it is? And he was telling that he thinks it's stroke. So
Yeah.
I think Sophia asked that what he thinks about it, and then
No.
Sophia
Yeah,
asked something else.
yeah. No, and she used windows of opportunity. Once I said I'm worried, then she jumped in and said what you're so concerned. She used it, and that was good. Okay, but one of the questioning was little bit formulaic. Either the concern, either
Maybe
the
expectation.
ideas.
Maybe expectation, isn't it? I said like we'll do whatever is best for you today, but
Yeah,
do you
exactly,
have anything
exactly,
specific?
yeah, exactly, yeah, exactly. So one of them was just little bit formulaic, so just take care about it, okay? And other than that, I'm happy. Okay, your flow and your interpersonal skill was fine. It's just the tricks in the management plan.
Yeah,
You just
it was
trip on
easy,
it.
but yeah, but I
No,
don't know.
no, it's not
I
easy.
really don't come
No,
to my
no,
mind.
it's not easy, because the people will miss that it's herpes, is Ramsey Hunt, and they will treat it as normal, official nerve pulsing, okay, or pulse pulsing. Okay, asking about trash here was a crucial, okay. And the other trick is about, the bloods, about diabetes, promoting the vaccination, okay, and then the safety netting about the red flags that can happen. This is one. And the follow up here is very important. Okay, and maybe explaining that if the symptoms is not improving, that's why I told you, do I need to go to specialist? Do I need to go to specialist just to see how what you will say? So that I was trying to tease out this from you. Then you need to tell me if there is no improvement, we might refer to the specialist. There is a lot we can do. One of them is galvanic therapy, okay, or Botox injection around the eye, as well as if you start your eye to become, painful, or your eyes is not start to become inflamed, because one of the drawbacks of orbicularis oculi paralysis, that you can have corneal ulcer, and this is sight threatening complication. So these are the safety nettings. Okay.
Okay.
Yeah.
Yeah.
Shall we go through then because I will throw some also other challenges in the management while we are discussing the case of upper and lower motor nerve injury of the facial nerve, and there will be at the end of the lecture there will be a question. If someone can answer it now, well and good. If you want to answer it when I post the video on the YouTube. So the first right comment, he will be guaranteed 1 hour teaching with me, okay, for free. Okay, so stay tuned. Okay, so for you guys, how you will differentiate between upper and lower motor neuron lesion for facial nerves? Can someone tell me? Doctors?
Upper space, upper.
Okay, so your upper space is what?
Upper space, upper. So if it's a upper motor neuron nerve, if he wrinkles the face, then it will wrinkle.
If the face is wrinkling, so it's upper motor.
Yes.
Exactly. Okay, do you know why?
No.
Okay, so we'll
Because it's
explain that.
My
It's
last
double nerve
upper.
reach. Double nerve
It
reach.
is
Yeah.
because the dual supply.
Yeah, exactly. So double innervation of the occipitofrontalis from the both cortex will make it spread. Then, so the more challenging question, then if the patient have bilateral facial, then how you will know if it's upper or lower? You didn't see from before bilateral facial palsy? So how we will know if it's upper or lower? Because that's important to refer to the hospital or as an urgent, because if it's bilateral facial nerve, you need to refer. But do you need to refer him now to the hospital to go to the emergency, or you can refer him to the NET at a non-urgent basis? Or urgent, but not now, not immediate referral. So how you would know if the patient have bilateral facial nerve?
A stroke can't be bilateral. It should be the facial nerve palsy due to like a Bell's palsy after viral infection.
Why a stroke cannot be bilateral? Well, you can have brainstem infarction, yeah. So there will be other symptoms. Will not be only facial, is it? But the other thing, if patient is coming with one facial palsy and he have a stroke in the other one, so he already have later on a stroke, and then he came with facial nerve palsy, how he will differentiate this is another stroke or complete, So if bilateral paralysis, how he will differentiate it's upper or lower? Because it's still stroke can be bilateral.
Yeah, so if it is if it is a stroke, then always it will be the forehead spares.
Even if it's bilateral? Bilateral paralysis? Do you think if you have bilateral stroke, he will, so if you have, for example, brainstem stroke, so it will affect the nucleus. Do you think it will be flaccid, but it will be, the forehead will be spared? So it's not supranuclear palsy, it will be nuclear palsy if you have a brainstem. So how you would differentiate?
So it will have bulbar symptoms.
Yeah,
like
this is one. So there will be other symptoms. And what about the type of the paralysis?
It will be lower motor neuron paralysis.
So what is the difference then between that and
With
that?
the upper neuron paralysis will be spasticity with
Yeah,
the
exactly.
lower,
Yeah.
with the lower will be
you will
flaccidity.
you will return to the basic. Yeah. So flaccid paralysis and fasciculation it will be in the lower, in the lower motor, but in the upper motor you will have spastic paralysis and no fasciculation. That's also important. For sure, less likely to, this will not appear in the exam, just for you to know. Okay. So the other thing, little bit about the anatomy, because it's important in the differential. So we need to know that the facial nerve is not a pure motor nerve, isn't it? So what other things that will be affected? Which I said in the complaint of the patient. I said, "Oh, I have excessive, tears. I have excessive tears, doctor." So what else the patient should be expecting that it will be affected? Otherwise, he will be panicky. You need to explain that. So the motor nerve, so the facial nerve is not pure motor nerve, is it? What else is supplying in your
So it's
face?
supply the face, tongue, and all
Okay.
the most of the glands.
Exactly. So the tongue, what it's supplying in the tongue?
So
Taste,
anterior
yeah?
2/3 of
Yeah,
the tongue.
don't taste. Yeah, yes.
Taste.
Yes, and so coming back to supplying most of the glands. So if it's supplying, it's supplying the saliva and the lacrimal gland, isn't it?
Yes.
So why then there is excessive tears? Why the patient is coming with excessive tears usually with facial nerve affection?
I think it's the fifth nerve also supply the
blinking, yeah, well, yeah, fifth nerve, yeah, will supply, but why excessive tears? Does it make sense? I mean, if the facial nerve is supplying the lacrimal gland and supplying the salivary gland, yeah. So why the patient will come and it's complaining of excessive tears in the eye that's usually affected, in the side that's usually affected with the facial nerve affection?
I think it's because of impairment of one of the muscles there that control, but I don't remember the name of the muscle.
Okay, so partially yes, there's multifactorial things. Okay, you need to know that the tear film is not a simple, yeah, it's not only water film. So the tear film is multi-layers. One of them is water, one of them mucus, one of them is lipopolysaccharide. Otherwise, the evaporation of the watery secretion of the tears will be rapid, and then you will have dry eye, whatever amount of water you will secrete. So the facial nerve is supplying the parasympathetic supply to the eye, to the lacrimal gland. Okay, and the parasympathetic is responsible about secreting the mucus, but the sympathetic system is still there. Okay, and will do excessive water secretion as a compensation. So because the mucousy part of the tear film is less because of the paralysis, then you will have you'll have more water, and the water will evaporate or will be excessively secreted just to compensate of the mucus part of the tears. This is one. The other thing, the orbicularis oculi, when it's paralyzed, so the intimate contact between the eyelid and the eyeball will be lost, okay, because the muscle will be flaccid, and that also will make the tear film, evaporate easily. And the third thing, the nasolacrimal duct is supplied by there is a muscle that keep it potent. So and it's supplied by the facial nerve, and then paralysis of the facial nerve will make the nasolacrimal duct collapse, and then the drainage of the tears will be less, and that's why the patient will have excessive watery secretion. Okay. The other thing why I bring this photo, that we need to know that also if you have cerebellopontine angle tumors, that will affect the facial nerve. And here that is important then to ask about other facial nerves, okay, other nerves that's supplying the face. And Sophia did ask about hearing loss. So the hearing loss is important. So you would know if there is any problem with the vestibulocochlear nerve, okay, because if there is if there's a tumor here, it will compress the facial nerve and the vestibulocochlear, namely if there is a schwannoma. So schwannoma usually will come with the vestibulocochlear and seventh nerve and the trigeminal nerve affection. Is that clear? Yeah. And
Yes.
actually, in the facial nerve paralysis, is the hearing is decreased or increased? Does anyone know?
I think it's hyperacusis.
Yeah, why?
Hyperacusis.
Yeah, why? That's right. Why?
I don't know. I can't remember the
Yeah,
birth of it.
yeah. So because we have this, you know, the three ossicles of the ear. We have three ossicles. Yes, we have three bones that transmit the infection, the sound. So when the sound is collected by the external auditory canal and then going to the drum, and then we have three ossicles or three small bones. The what is the responsibility of these three bones? So the you know, the kinetic energy or the sound energy should be transferred to the eardrum and then will be transferred to kinetic energy through the oscillation of these bones. And one of these bones are called stapedius. Okay, and the stapedius are connected to muscles. This muscle called the stapedius muscle. And the important thing in this muscle is damping effect of the high kinetic energy or high vibration energy of the sound wave to be less kinetic energy in the oscillation. And when these muscles are, you know, paralyzed, then the damping effect will be gone. Okay, and then the wave energy will transfer to high kinetic energy, and that's why you will hear the voices are more louder. Is that clear? I hope I didn't make you confused. Clear?
It's clear, thank you.
Yeah, it's clear. And then the third thing, or the third, you know, the third transfer is for the kinetic energy from the sound, you know, from the movement of the ossicle. There's the movement of, you know, of the fluid inside the utricles and vestibular system, and then this will make the, you know, the hair of the terminal, you know, that the nerve terminals of the vestibular nerve to move, and then that will change the kinetic energy to, you know, electrical energy, and then will go to the brain and you will hear. Okay. It's away from the facial nerve, what we are talking now about, but this is how you are hearing. Okay. This is a you know, just another diagram just to demonstrate. And then the reflexes, you know, the other important thing that the tear film will be affected, the test can be affected, and the stapedial reflex can be affected. Then the other differential that you need to know, also the facial nerve can be affected when it's in the middle ear, isn't it? So you have, this is the bones, okay, and then the facial nerve will come out, and then the vestibulocochlear nerve will come out in the same site, okay, and that's why schwannoma can affect the facial nerve. And both of them will go to the internal auditory canal, and then from the internal auditory canal, you know, will be relay of the vestibulocochlear nerve, but then the facial nerve will go to the middle ear and move. So if you have any problem in the middle ear, if you have otitis media or cholesteatoma, okay, that can affect the facial nerve. Okay, that's why also this is why you are, when you are asking about hearing loss, you are excluding these two things, the schwannoma and also middle ear affection or middle ear infection. And then from the middle ear, the facial nerve will go through the mastoid process. You know, they have here the mastoid process and then the mastoid foramen, and will go out. Why this is important? Because at this foramen, okay, if the facial, when the facial nerve becomes swollen for any reason, then it can present with facial nerve paralysis. And that's why facial nerve is more common in winter, okay, because inflammation of the nerves can happen in winter more. And the other thing, more common in pregnancies. So pregnancy, you have generalized edema, okay, then the facial nerve can be simply, you know, edematous, and then compressed around the, you know, the mastoid foramen, and then, you know, present with facial nerve paralysis, as well as if the patient, you know, have, you know, I make a video from a week ago about Paget disease, and Paget disease of bone can make excessive bone formation around the mastoid foramen, and also will cause, you know, facial nerve paralysis. Okay, so facial nerve paralysis have very big differential, so keep your mind open, because it can present with, you know, multiple presentation, multiple diseases, not only, you know, herpes simplex infection. This is another diagram to show the nerve to stapedius. Okay, so in the middle ear, this is nerve to stapedius, and then and that's why you will have hyperocclusis. And these are the terminal branches of the nerve, of the facial nerve, okay? And all of them are motor, okay? You have the temporal, okay, which is supplying the occipitofrontalis muscle. Sorry. The temporal, which have occipitofrontalis muscle, which have double supply. That's why the occipitofrontalis with the upper motor is not affected. We have the zygomatic, and this is supplying the orbicularis oculi muscle. We have the buccal nerve, which is supplying the nasolabial fold, and then the platysma with the cervical, and then also the marginal mandibular nerve is supplying the muscle around the mouth. So when the patient is coming to you, how you will examine him? Dr. Sophia or anyone else, how you will examine him? Because it's you might do the whisper test for the hearing, but how you will examine the motor nerves, how you are examining the motor, because this is the most important in your in your clinic.
With the facial nerve.
Yeah, so how you will what you will tell the patient? What
So
are the five
we ask them
movements? Because you have 5 terminal branches, isn't it? The 5 motor branches. So you need to examine the 5 motor branches. So what usually you are asking the patient to do?
So we ask patient to show us their teeth or smile, blow air
Okay.
into their mouth,
Okay.
put wrinkles on their forehead,
Okay.
and ask them to close the eyes and don't let us open.
The president said yesterday that the Assad regime or Assad himself should.
I'm not sure who's talking. Okay. Yeah, I'm with you, Sophia. Hello?
Yeah.
Yeah,
Yeah,
and
and
grimace,
we can
grimace for the platysma. Okay, so temporal branches are browning. Okay, and then zygomatic branches close against resistance, and that's important also. Why? Because according to the muscle weakness, you will decide to keep the patient in the primary care or to refer him to the secondary care. Because if the patient have massive weakness or we come to that 6th or 5th grade weakness, you don't need to keep him in the primary care. Please refer him from the start, because massive weakness usually will leave residual nerve affection. So starting the patient early on physiotherapy will make the recovery better. Okay, and then blowing the mouth, and then showing the teeth, and then grimace for the platysma. Okay, you don't need to save that. You need to know by heart. Okay, it's just the house Brackman classification. If the facial nerve is normal, then all of the areas are functioning. If there is total paralysis, this is number 6. So number 5 and 6, this for you need to refer him to the ENT or neurology, some areas, but usually here in my area we are referring to ENT. Okay. Okay. So this diagram is just to show the difference between the upper and lower motor neuron and what is the idea behind the occipitofrontalis spare, and then what is the difference between upper and lower motor as we discuss. Okay, if you have bilateral, and these are the differential of facial nerve paralysis in general. Okay, we have acronym is vitamin D. So vitamin D. So either vascular, having a stroke, or cerebral or aneurysm, or idiopathic, or iatrogenic if the patient have history of parotid gland, operation, or middle ear, operation. Traumatic, also asking about history of trauma is important because traumatic brain injury can present with facial nerve. I remember that I had a child 7 years old after traumatic brain injury. Unfortunately, we forgot to examine his cranial nerves, and then after recovery, we find that he have facial nerve paralysis, and we missed the boat. Unfortunately, they need to do micro reattachment or microsurgery to, you know, to recover the facial nerve, and the recovery was not 100%. So, so also keep that in your mind, okay? Metabolic, we already said diabetes, and then inflammatory as Ramsay Hunt or Pill's palsy, or also if you have recurrent in bilateral or recurrent, you know, facial nerve palsy, it's one of the indication of referral, because you need to exclude, you know, multiple sclerosis, okay, MS, or even TB or tick bites. Also, one of the things that are, you know, Lyme disease, one of the causes that can cause recurrent nerve palsy. Okay, developmental, you will have history, you know, the child, you know, since birth you have problem. Coming to the statistics, how Pill's palsy is common. So you can see it's 1 in 5,000.
Can I ask a question,
Yeah,
Dr.
sure.
Samir?
Sure. So, but
Um,
can you just tell me who you know, if you can introduce yourself, just doctor,
I
because
raised my hand. Can you see
yeah,
that
sure.
raised?
No, I need just, can you introduce yourself? What's your
Yes.
name? Because I can't see who's talking with me.
My name is
Sorry.
Dr. Samra Tanvir.
Okay, Samra. Yeah, how can I help you? Tell me.
Yes, this is my first time I'm attending this session today.
It's my pleasure that you came to see me.
Thank you. So because I was concerned that when we do SCA, of course we don't do examination, yes? So how do we
No.
mention this examination part in between? Like, do we ask those patients that do open your mouth or like show your teeth?
Okay, so we came over that by putting the photos, the pictures, yes. So already the nurse asked him, okay. Usually there is no mark in the exam for doing the things. So most probably if this came, it might appear as a phone call, so you will not be able to tell him to do this, you know, movement, and they will send you the picture. But you need to say what you will do well, because that's why I asked Sophia. You want to bring the patient in. It's not enough to say that in the exam that I want you to come in to examine you. You need to say what you will examine. So you might tell him, okay, I need to bring you in, I need to examine you, I need to take your numbers, your blood pressure, check your sugar, also to do some movement with your, I will ask you to copy some movement of the face to just make sure which muscle is affected.
That's perfect. Thank you so much.
Yes, no problem. And then, so Pill's palsy, which is idiopathic or herpes simplex infection of the nerve, which contribute to 3/4 of the cases of the lower facial nerve palsy, unilateral flaccid paralysis of the facial nerve. Okay, and as we said, Pill's palsy common in winter and common in pregnancy. Okay, and then spontaneous recovery will happen in 70% of the cases. Okay, but unfortunately, there will be small percent of cases that they will not have complete recovery. Okay. A complete recovery usually will take from 6 to 9 months. So putting realistic, because also that's why I asked Sophia, well, I will improve in a month, in a week time, doctor. So for the sick note. So yeah, and she said no, sometimes take months. So you need to tell them from 6 to 9 months. So putting a realistic, realistic plan for the patient that will decrease the frustration of the patient. This is one, and will decrease, the number of calls you will get from the patient. Okay. And then you need to know that Pill's palsy is diagnostic of exclusion. You cannot just, so that's why you cannot only, diagnose Pill's palsy over the phone. If the patient is presented with facial nerve paralysis, please bring him in. Don't diagnose that over the phone or over video calls. Bring him in, do complete neurological exam, just to make sure that there is no other sinister causes are hidden. Okay. What you should look for? Okay, you should look for bilateral or recurrent, because that you need to do demyelinating, and bilateral recurrent nerve affection, that's an indication of referral. If the patient generally unwell because of the sarcoid and the limb disease, rash, as Sophia said, to exclude the Ramsay Hunt syndrome. Okay, also you need to check the parotid gland to exclude any parotitis or parotid tumor. Okay, and also other neurological signs. We talk about the red flags, we talk about the history of trauma and bilateral, and usually facial nerve is coming to child, don't hold it in the community. Children always refer, okay, because usually there will be a sinister causes behind it. Rarely to be herpes simplex, okay? Usually there will be something else happening around. So if you had a child, just refer him. Don't continue treating the patient in the primary care. Management also, according to the rule of three things: steroid, antiviral, eye care. Always thinking about it. Okay, steroid. What is the window? The time window of the steroid is 3 days, 72 hours from the onset of the paralysis. And what is the use of the steroid? Why it's useful? The steroid because it's help in the speed the recovery and decrease the sequelae. Okay, that's need to be explained to the patient, especially in that patient because he's diabetic, and there is high chance that his diabetes will deteriorate with the prednisolone doses that we are giving. So keeping, convincing him about the drawbacks and the benefit of the prednisolone or the corticosteroid is important. Otherwise, he might later on, send a complaint. Yeah, you did a good job, but you didn't explain properly to the patient, and you ignore that he have diabetes. Then he might send a complaint. The question is, if this patient started to have high blood sugar level, what you should do? How you will manage that in the primary care? Because it's not uncommon. The patient is diabetic, you give him prednisolone, his sugar become high. Yeah, you will monitor it. And then if it's high, if it started to shoot high in the sky, what you should do?
Do we discuss with endocrinologist?
Okay, that's fine if you want. That's not wrong. The power of GP, that is, he can ask anyone. But if you don't want to ask,
I will ask him what medications he's already on. Like if he is taking metformin, he should continue taking that and do
okay.
not stop his medications. If he's on insulin, then he can double the dose of insulin for
Yeah,
that period of
no,
time.
well, not double. Yeah, be cautious. A little bit, go slowly. No need to double. Usually, I'm increasing 2 to 3 units, okay,
2
per
to 3
day.
units, yes. Okay.
Yeah, and then following up. But if he's not in any of that, what else? Well, what is the guidance is saying? If you have uncontrolled blood sugar in general, and you want to control it, and the patient, until the oral therapy will be, it will take time until you reach proper control. What are the things that, yeah, insulin is one of the things that you can start even the patient on if the patient is happy, but mostly he will not be happy to take injections. Well, what else you can give? What is the other recommendation of the guidance? This is in the first page of the guidance. Diabetes is very important for the exam and your real life. So what is the first, what are the lines of therapy if you even have a patient with diabetes, first time diagnosed diabetes, and that the diabetes is very high, and until you start the oral therapy, the normal oral therapy, that will take time to control the sugar. So you might use a transient therapy to control his diabetes level
Sulfonyl.
until, yeah, exactly.
Sulfonyl.
Sulfonylurea. Yeah.
Yeah.
Glyclazide, yes. Glyclazide, and or insulin. And usually the usual dose I start in 40 milligram, and then I increase according to the response. Okay, such patient is always better to have, glucometer at home. Please don't just, start him in prednisolone without having a glucometer. Okay, especially if the patient is diabetes, please. And the regimen that recommended by the CKS, either 25 milligram twice daily for 10 days or 60 milligram for 5 days, and then drop on 10 milligram for another 5
So
days.
sorry,
For,
Dr. Salim. So we add
yeah.
glyclazide with prednisolone, even if he is not on that regularly.
Yeah, if he's diabetic and he starts his sugar to shoot up, you can
Mm-hmm.
start glyclazide or insulin, even if he's not on that regularly. Yes,
Okay. For the
just
duration
until,
of
yeah,
prednisolone.
for the duration of treatment of prednisolone.
Thanks a lot.
Yeah, yeah, and that will put something else that you need to safety net if he's driver. So this is a driver that is, on type 2 drive, heavy load driver. So and if he will usually he will not continue for sure, driving, but you need to safety net him. Okay. And then the antiviral. So the antiviral is not useful for the simple herpes simplex infection. The only time that you need to use the antiviral with the Ramsey-Hunt syndrome. Okay, again, Ramsey-Hunt syndrome is herpes zoster opticus, is herpes zoster reactivation affecting the facial nerve. So then you need to start the acyclovir, and we said the dose of about of the acyclovir 800 milligram 5 times a day for 7 days, and we discussed a little bit about the drawbacks of the oral one: abdominal pain, diarrhea, skin reaction, and vomiting and photosensitivity. Eye care is also important, so you need to tell the patient to either, when you are examining him, you will see if there is a complete eye closure or not. Okay, and there is no complete eye closure, you will start some lubricant, eye ointment, eye patching, and sunglasses. If at any time you are worried about the eye, so refer to ophthalmology, because they can do either Botox injection or tarsorrhaphy. Okay, but they can close the eye by surgical operation until the complete healing appear. Anyone know what is crocodile tear syndrome?
I just know in general, crocodile tear means faking, not real tears, but I don't know about the syndrome.
Okay, then maybe this is a woman tear, I think. Yeah, faking? No, it's not faking. It's not faking.
Yeah.
But I don't mean the woman tears. Crocodile tear is not the woman tear. Don't misunderstand. I'm joking, okay? Don't take it as of offense, please,
But
doctor.
Dr. Salim, nowadays it's
Yeah.
2024. Women don't cry, they may cry.
Oh yeah, well, I'm with you. Okay, yeah. Got to protect
I'm a
us.
woman myself, so I'll support
Yeah, I
women.
know, I know. Okay, so I can't agree
So
more.
the
I
rules are
can't
now
agree
changed.
more.
Don't
Yeah,
cry, make the person cry.
yeah, I can't agree more. Yeah, for sure, without doubt. So what is the crocodile tear syndrome? It's one of the complications of facial nerve paralysis, especially if there is a problem in the parotid gland. So regeneration of the 5 terminal branches of the facial nerve can lead to additional generation of communication. Okay, and that the mandibular nerve is supplying the mouth. Okay, and then at the same time our supply the facial nerve the mandibular branch of the facial nerve is supplying the mouth, and at the same time is supplying the lacrimal gland. So sometimes the regeneration or the reanastomosis of the facial nerve terminal branches will be mistakenly attached. So when you are moving your mouth, that will stimulate your eye, okay, or the lacrimal gland. So the patient, when he's eating, he will start to cry, okay, and this is the crocodile tear, okay. This is not the question that I want, for the price, okay. The question of the price is coming at the end. Okay. The other thing, when you need to refer, so you need to refer, as I said, if recurrent, bilateral, or if there is no improvement after 3 weeks, or there is no resolution after 3 months, then you need to refer to ENT. In my area, or in some areas, there's neurology, or even if there's eye problem, then you need to refer to ophthalmology. This is just simple summary about it. This is checklists, what you want to ask, and what, if you put that in front of you in a case of facial nerve palsy, I think will be more than enough. If you go through these points, that you will be able to pass the exam, okay, or the case. Okay, it's just a checklist to remind you what are the main points, okay, that you need to go through them. And then some of the, troubleshooting that I did it with Sophia. And I think that will cover the topics more than enough. Okay. The peers we get, the pitfalls, we already say, we go through them. Okay. Just be aware, doctors, that we have a YouTube channel. Please, I will be very happy if you can join it and subscribe on it. Okay, and see the videos there. There's more than 25 or 26 videos there, and I will keep posting more videos and videos. I promise that there will be a lecture series about emergencies in the GP land. Okay, I will post them one by one. I will start, I think, this weekend recording them. Okay, and then don't forget to to join the WhatsApp group or the Telegram group. And then if you need any further help and support, you can call me at any time. Be aware that I'm doing some mini mocks as well, and I'm doing, one-to-one teaching. So if you need any further support, I'm more than happy to help you. The question of the day, okay, how you will differentiate between the cortical, so if you have cortical facial nerve palsy or supranuclear facial nerve palsy. So the question of the day, how you will differentiate between cortical facial nerve palsy, so affection of the cortical area of the facial nerve, or having supranuclear, mean that any lesion in the white matter, okay, like white matter ischemia or even tumor in the white matter, because there is a way to differentiate. Okay, it's a difficult question. Okay, if someone know the answer, I'm more than happy now to hear it from him. If no, when I post the recording in the YouTube channel, please try to answer it. The first doctor who will answer it, he will have a free one-to-one teaching with me. Okay, and I promise he will learn a lot. Okay, I'm open to any question, doctors. I finish now my lecture for today. I hope it is helpful, and I'm more than happy to take any question. Otherwise, we will just we'll just end the teaching. So I'm more than happy to take any question. I will just try to stop the recording. Hopefully it will work. Just if the people are shy from.
Dr. Salem.
Yeah, sure.
Hi, my name is Evie. Can I ask a question, if that's okay?
Yeah, without doubt.
Yeah. This is also my first time here. Thank you very much.
No problem.
So in the SCA, for instance, when we are doing differential diagnosis and we are sort of asking direct questions to rule out, to see whether it's Bell's or Ramsay Hunt, is it just the rash in the ear that we use to differentiate? So if there's a rash in the ear, then we think, okay, likely Ramsay Hunt. But if there's no rash, but the same thing's going on, then we think likely Bell's.
Yeah, 100, 99% yes, but some cases, the rash will appear later. Some cases the rash will appear later. So and it's very difficult something like that to appear in the exam, but in the real life you need to know. So one of the safety netting of the patient coming with Pill's palsy, okay, not Ramsay Hunt. If the patient presented with Pill's palsy, when you are safety netting him, you will tell him, if you had any rash at any time, you need to contact me. So because once the rash appears, you need to start the acyclovir.
Okay, so if someone comes in with Bell's palsy,
yeah,
it will usually
one
be
of the safety. Yeah, for sure. Yeah, without doubt. If it's Bell's palsy without rash, it's only prednisolone, provided that he came within the 72 hours.
Okay.
And then when you are safety netting him, okay, you will tell him, this is important, and will have a mark. When you are safety netting him, you need to tell him at any time if you had any rash or vesicles appear around your ear or your face or even the mouth, because the rash of the herpes zoster opticus or herpes zoster oticus can appear in the ear, external auditory canal. That's why you need to look at inside the ear of the patient. So it can be in the external auditory canal, can be in the auricle, okay, can be in the palate. So you need to open his mouth and see if there is also any vesicle or rash inside.
Okay, thank you very much.
No problem, no problem. Any other question, doctors? Okay. Well, I'm struggling to close my. So, are you happy, doctors, to finish it? Shall we finish it?
Dr. Salim, the question that you asked, when you will
Yeah.
answer this in the next Wednesday teaching?
Well, I will. I will leave it at least 1 week so the people can, I'm giving a chance someone to answer it in the YouTube channel.
Okay.
Because I think it's worth, it's worth. If you answer it and you know it, you will learn first because you will search. So this is way to, to make you learn. The other thing, I will give you 1 hour, teaching free, me and you, okay? We will discuss whatever you want, or you can have some mini mocks with me on this 1 hour, okay? So you will win. It's a double win. So you will win the free teaching, and you will win also the new information that you will gain.
Wow.
And I
Thank
will
you.
answer, yeah, and I will answer next week for sure, without doubt.
Thank you so much,
Yeah,
Pai.
no problem, no problem. Take care, take care. So I will, because I cannot end. I don't know, my face, my screen is stuck. So I will, I will just ask you all to just leave, and then I will try to, because I don't want to lose the recording. So if you are happy, doctors,
you.
no problem
Thank
at
you,
all.
Salim.
No problem at all.
Thank you
No
very
problem.
much.
No problem. Take care, doctors. Take care.
Thank you.
No problem. No problem at all. No problem.